and welcome to our fireside chat on navigating the complexities of genetic testing. I'd like to start by introducing our special guest today. Our first guest is Megan Zornecki. Megan is Chief Operating Officer of InformedDNA, where she oversees clinical genetic operations and has been with the company for almost a decade. Megan has deep subject matter expertise in genomics, utilization management, telehealth, and medical policy. Our second guest is Dr. Amin Morhadi. Dr. Morhadi is Medical Director of Integrated Oncology at HealthHelp since 2012. He's a board-certified radiation oncologist and currently serves as faculty physician at Cedars-Sinai. His primary clinical and research interests include breast cancer, lung cancer, and brain tumors. Dr. Morhadi has published several articles in prestigious journals and has written many chapters for textbooks that are widely used today. I welcome you both. Moving to our first subject, the increasing complexity of genetic testing. And Megan, this question is for you, and it's a two-part question. Can you describe the current landscape of genetic testing and the challenges it presents? And as a follow-up question, how does this complexity of genetic testing impact the need for utilization management?
Thanks for having me, George. Happy to be here and happy to dive into this subject. On the first topic, the current landscape of genetic testing is growing really fast. So we're expecting that annual spending on genetic testing is going to reach $36 billion by 2026. That's up from only $11 billion in 2018. So it's really growing quite quickly. If managing this spending is not a problem for health plans already, it certainly will be in the next few years. I think above and beyond just the size of the market, we're also seeing really rapid technological advancements. So 10 to 15 years ago, everyone was really excited about next generation sequencing, starting to think about panel testing for multiple genes in a single assay. Now we're routinely testing for over 100 genes at a time. Whole genome and exome sequencing are really standard of care now for many conditions. And even more recently, we're starting to see the development of new, really complex tests like gene expression classifiers, polygenic risk scores. And these are technologies that are new even for genetics experts, let alone, your average practicing primary care physician. So we've got a big, fast-growing market. We're seeing a lot of technological advancement. But a real challenge there is that the interpretation is not necessarily keeping up with the technology. So in many cases, our ability to technically perform a test has actually outpaced our ability to interpret and use those results clinically. And that can lead to a ton of confusion about clinical utility, appropriate indications for testing, and even appropriate patient management following those test results. Finally, I think it's important to mention some of the advances we're seeing in treatment. So in the last few years, we're really starting to see some, very exciting advances in the treatment of classic genetic conditions like cystic fibrosis, spinal muscular atrophy. And then we're also seeing really significant changes in the way we think about treating certain types of cancers. All of these new therapies then also change the way we use and think about using genetic testing. In some ways, that's really flipping, kind of our old paradigms on their heads. And at the end of the day, providers and payers really need to be keeping on top of this to keep up with the current best practices for genetic testing. And I think, to answer your second question regarding how has all of this complexity impacted the need for utilization management, a really complex, fast-growing, expensive area of medicine, this is, a requirement for utilization management. This really high volume of new tests are very hard for payers to differentiate. CPT coding has not kept up with the rapid pace of genetic testing. So payers have a really hard time differentiating apples from oranges. And sometimes they even have a hard time applying their own medical policies to claims that are coming in. So we really think that utilization management, and especially utilization management by genetics experts, is critical to managing this segment of the market. I think another important element to consider is the limited ordering provider experience and education on genetics. So your average physician really doesn't have a lot of experience or expertise managing, ordering, interpreting these tests, and they often rely on laboratories for a lot of guidance. And of course, this is something that can really lead to overutilization in this space. And then finally, I think just given everything I've mentioned so far, you can tell this is a really quickly evolving space. And that means that guidelines and evidence are changing extremely rapidly. They need to be reviewed almost continuously. And I think that's something that can be really hard for payers to keep up with as well.
Thank you, Megan. Moving to our second subject, the impact of genetic testing on cancer care. And Dr. Marhari, this question is for you. How does genetic testing inform clinical decision-making in medical oncology? And can you share an example of how genetic testing has directly impacted a patient's cancer care journey?
Definitely. And good morning, George and Megan. Nice to see you. So there's several different ways that genetic testing in general, or just genetic analysis of tumor cells or human DNA, has led to alterations in how we view cancer. I'll never forget, when I started out in oncology about 25 years ago with my residency at UCLA and then 19 years here at Cedars-Sinai. The very beginning, it was just a very broad, generalized treatment utilizing chemotherapy, radiation, surgery, and everything was sort of bucketed like that. And it's sort of been, I would call it a privilege to have been involved in this rapid transformation to genetic testing and genetic analysis, and to have watched it spin into multiple different directions, all of which have improved overall patient care. Of course, there have been bumps in the road, and there's been a lot of there's been such a rapid, pouring in of information that it's been really hard to keep up. But I do think, in general, the field of oncology has been doing a good job keeping up and sort of understanding how to implement these thought processes. So the way I think about the DNA analysis, whenever people say genetic testing, I mean, obviously there's a genetic component, but very often that implies you're looking for some kind of hereditary risk. But at the end of the day, the genetics of a person's DNA has multiple different applications. And I sort of like to break them down into a few different buckets. The first bucket is somatic tumor testing. And I think the best known example of this as an oncologist, particularly one who specializes in treating lung cancers, would be like an EGFR mutation in non-small cell lung cancer. But of course, there's several other mutations that have since kind of come onto the scene and have modified therapy. But that's one broad bucket of how genetic testing, quote unquote, has influenced outcomes and treatment pathways in the treatment of cancer. And the second thought process is pharmacogenomic screening, and that's determining if there's some patients who might be much more sensitive to reactions of certain types of chemotherapy, like 5FU or mitomycin and things like that. And there's been a lot of research that has pointed to how we can analyze this in a way that is truly, you can avoid it in patients where there might be an adverse reaction. You can also test to see if they're sensitive to it in particular. And another thought, and then another way is where you can utilize genetic testing and analysis using these microarrays, looking at various genes within a tumor to see if they respond to certain treatments or not, right? One of the more common examples of this is oncotype testing. But there are a lot of vendors out there it's still, I would say, in a relatively fledgling state, but there is good information that we are getting from those thought processes to see if, hey, some people really benefit from chemo or really benefit from targeted therapy, or maybe you should just leave them alone because their outcome is good enough where it's not warranted. So those are three ways, and I think there's a final way that people have to think about it, and that's hereditary testing and germline testing. It's becoming, I work here in Los Angeles, and there's a lot of private doctors and people, who have resources who will order all of the various tests that are out, available to them. Myriad is one example, but there's several different tests that you can order. They do a mouth swab or they do a blood draw, and they analyze your DNA for sometimes up to 450 genes. And they'll tell you, or they will try to tell you as best as they can, hey, you are at risk for X, or you're at risk for Y, or you're at risk for Z. And then sometimes unfortunately, we don't know what to do with that information always, because sometimes people can say, oh, I have a 30% risk of colon cancer. Oh, what do I do? Take out my colon? And I think that part of it is still, in my opinion, a little bit the wild, wild west. And I think that the information has come on so rapidly that we really need to harness it into the proper decision making. And I think that's what's happening right now as we speak, as we assess risk, as we just don't go blindly, do double mastectomies or ovarian removals on patients who, don't have BRCA1 and 2, but they might have an ATM mutation. I mean, what do you do with that, right? And during our breast tumor boards in particular, we always have these debates about prophylactic mastectomies and how do we approach them based on this information that's relatively new. So those are the common ways that we think about genetic testing.
Thank you, Dr. Marhadi. Moving to our third subject, the future of genetic testing in medical oncology. Dr. Marhadi, will start with you again with the first question. How do you see the landscape of genetic testing in medical oncology evolving in the future?
So how do I see the landscape evolving in the future?
Correct.
I think there's going to be much more. Right now, I think the technology exists where we can analyze the DNA and we have an understanding of what these mutations are. Now, I think it's going to evolve with translational research into clinical applications, how it's going to apply to lung cancer and breast cancer and brain tumors, etc. So that, I think, is the most important next step, is to put it into the clinic and test it. I think that I would personally like to see less bench research and more clinical translational research to really see how, certain targeted therapies interact with patients, or, more importantly, let's take Oncotype for breast cancer, for example. Are we really sure that omitting chemotherapy based on Oncotype results has longevity 5, 10, 15 years down the road, where we really did the right thing for the patient? So I think that's the most important direction that genetic testing needs to go.
Thank you. And Megan, same topic. We both discussed the complexities of genetic testing. What strategies can help an executives employ to navigate these complexities?
Yeah, I mean, I think there's a few kind of simple ones. First and foremost, I think you need to ensure that you're using true genetic experts in this space. It is complicated. It's rapidly changing. You need people who know what they're doing, writing your medical policy, reviewing the evidence, keeping up with guidelines. I think second is really, this is a space where prior authorization still makes a lot of sense. It's really important to use prior authorization here as a means of steering that best practice clinical care, given everything Dr. Marhadi mentioned and some of the challenges that I mentioned too. This is a complicated space. CPT coding is not adequate. And so it's really hard to manage genetic testing just by, for example, claims edits alone. And then finally, I think, as Dr. Marhadi alluded to, we really need to prepare for a further integration of genetic testing into oncology management. And that goes to, some of the things Dr. Marhadi was mentioning about treatment, clinical outcomes, things like that. But there's an area where we really see the field moving, is to be really, fully integrated into oncology.
Thank you, Megan. Well, this brings us to the end of our discussion. Based on your feedback, it's clear that genetic testing management as part of an integrated oncology management strategy will benefit the patients first and foremost, but also will enable providers and health plans to enjoy better care outcomes. I want to thank you both for your time and your insights. Thank you.
Thank you, George. Thank you, Megan.
Thank you.